Okay. Hello, everyone. Thank you for that kind introduction, and thank you to our earlier presenters, Dr. Schreiner and Ms. Chavez. I thought that was very informative. So today, I am tasked with talking about MS research updates. And as always, there's been a lot of interesting things that have happened in the past few months, and never enough time to go over everything, but I will do my very best. I think this is my first time doing research updates. So if it doesn't go well, I'm sure they'll bring back Dr. Alvarez for the next one. All right, next. So nothing really relevant in terms of disclosures for today's talk. And here is the kind of outline of what we'll be reviewing. First, BTK inhibitors, which if you've attended these talks in the past, you would have heard about before. We have some updates on those. We're going to talk a little bit about menopause in MS, which is a topic that I often get questions about. Aging and remyelination, another hot topic, and neuroprotective/remyelinating agents. And then finally, I think there's a slide in there on CAR T therapy that we'll hopefully have time to go over. Okay, so BTK inhibitors. This is a list of the drugs that have been studied or are currently being studied in the MS space that act on this pathway, specifically this enzyme. And it is interesting, we think, because in the MS space, because these molecules act both on the adaptive immune system, meaning like your B cells, so not so different from what we currently have in terms of treatment, disease-modifying therapies. But then also they can penetrate into the central nervous system, as you can see on the left in the yellow, and then there directly target certain cell types like microglia that we think have an important role in MS progression. And here I have another slide about that relationship. We've learned a lot more in recent years about microglia, which are a type of central nervous system resident cell that has a lot of important functions. They help to maintain homeostasis. They provide support to many different cell types, including neurons. They release cytokines, and we know in MS they can phagocytize or like swallow up bits of myelin debris. They exist in these two different kind of states, either pro-inflammatory or anti-inflammatory, so-called M1 or M2. And just to be clear, this is not something that you could easily detect in vivo. It's not like I can look at your MRI and say, oh, you've got some pro-inflammatory microglia there as opposed to anti-inflammatory. No, this is something that scientists are able to see when they do tests in the test tubes, and they can see that there are different patterns of cytokine distribution. But essentially, the thought is that these microglia might play some role in this, smoldering inflammation or neurodegeneration or whatever you want to call it, that seems to be driving progression in people who are experiencing progression in MS. And so hence targeting this cell, and especially might yield some benefit and help folks. So, but the proof is always in the pudding. So we go to clinical trials. The first one I'll be highlighting here is tolebrutinib in non-relapsing secondary progressive MS. This was a clinical trial or randomized control study that was published now a few months back in May 2025 in the New England Journal. So maybe already a bit dated, but still I think it's important to review. So this was in non-relapsing secondary progressive MS. So non-relapsing, so relapses. Why do we care about this? Like first, what is a relapse? I can refer you to a previous talk that I've done on separating relapses from pseudo-relapses. And I believe we have a question or two about this in the Q&A session afterwards. But, essentially this category, and I know that, Dr. Schreiner was talking a little bit about kind of how do we categorize folks with MS, but essentially we're trying here to distinguish between, relapsing forms of MS where we have, many different treatment options that are currently available that seem to work well, And then this more kind of chronic progressive biology that has so far not responded well to existing immunotherapies. So this trial, the Hercules study, enrolled over 1,100 participants with this non-relapsing secondary progressive MS. The EDSS, or the disability scale, ranged from 3 to 6.5, with an average of 5.5, meaning that these were folks who had at least a moderate amount of disability, including use of assistive devices to walk, but they were still ambulatory. This was not somebody who was wheelchair bound or bed bound. Average age of 49. Most did not have gadolinium enhancement, meaning active lesions on their baseline MRI. About 87% did not have active lesions on their baseline MRI. So they were randomized to either getting tolebrutinib or placebo, 2-to-1. And in the end, they found that tolebrutinib did reduce the risk of confirmed disability progression, CDP, by 31% compared to placebo. But there was still some progression among folks who received the tolebrutinib, and there was some complications with liver function, which 4% had liver function abnormalities in this trial, including one that ended up needing a liver transplant. And this is something that we have seen in this class of drugs, unfortunately, issues with the liver, and that we'll see again a little bit later on. But it gets a check mark, a green check mark, because this was a positive trial. Okay, and this is the kind of pictorial depiction of the main result, which was the risk of developing sustained disability for 6 months. And you can see the blue line, the placebo, the rate was about 30% or so, versus in the tolebrutinib arm, it was like in the 22% range. So statistically significant difference there. But then we move on to the Perseus study, also involving tolebrutinib. In this case, a randomized controlled trial, tolebrutinib versus placebo in primary progressive MS, up to age 55. The range of EDSS was 2 to 6.5. So again, including folks with moderate or moderately advanced disability. And again, a very high proportion of folks at baseline had no gadolinium enhancement. So this was what we would call 89% had no gadolinium enhancement. So mostly non-active MRIs at baseline. And the primary outcome was this similar kind of time to onset of a 6-month composite disability progression as the other trial. And what we saw here, and this was presented recently at our annual ACTRIMS meeting in February, was that compared to placebo, you can see those lines, they're really right on top of each other. So there was no statistical difference, no benefit, in other words, in slowing progression to tolebrutinib versus placebo. And so you might wonder, why would it work in secondary progressive MS, but not in primary progressive MS? And because many of us believe that, these are essentially the same, that the underlying biology is really, there's not a significant difference between the two. So the FDA had similar questions about that. And so initially they had submitted, and we were going to get yay or nay on approval earlier in 2025, and then it got pushed back. And then ultimately they were rejected, citing this unclear benefit and potential risk to the liver. So that gets a red X. Let's move on to another BTK inhibitor, fenebrutinib, produced by the drug company Roche. And they actually had a positive study in primary progressive MS. So let's look at the results of that. Now, first, so fenebrutinib, the trial was FENtrepid, and it was a non-inferiority study. So this is different from what we usually do when we do clinical trials, which is we try to prove that one drug is better than the alternative, placebo or whatever the standard treatment is. In this case, with a non-inferiority study, you're trying to show that what you are testing is not statistically worse by a pre-specified small margin to the kind of standard treatment, in this case, ocrelizumab. We've seen non-inferiority studies before, most recently with the discontinuation study, the DISCOM study that Dr. Schreiner alluded to, that was Dr. Corboy's project. And so it says here versus placebo. Sorry, that might be a little bit confusing. So the people either got fentrepid plus an IV placebo, or an oral placebo plus IV Ocrevus. So they're comparing essentially the two, fentrepid versus Ocrevus, in a randomized control way. And this was the results also presented recently at the ACTRIMS conference. They were able to demonstrate non-inferiority. And in fact, numerically, they reported even a 12% reduction in the risk of confirmed disability progression at 12 weeks compared to Ocrevus. Now, I don't think it doesn't look like it was statistically significant, but it met the bar that it was hoping to meet, meaning was not worse than the kind of standard treatment for primary progressive MS, which is ocrelizumab. And so this is another slide on that study. They noted that the strongest effect was observed in the 9-hole peg test. So that's a measure of upper extremity function, where there was a 26% risk reduction with fenebrutinib compared to ocrelizumab. They noted similar rates of adverse events and serious adverse events. But they did seem to have a higher incidence of liver enzyme elevations and an imbalance in the number of fatal adverse events, which is never a good thing. They did have 7 fatal events in the fenebrutinib arm in this study compared to 1 in the ocrelizumab study. They did not think that any of them were drug related. They were a bunch of different causes. But yes, that was noted. And then fenebrutinib, this same drug, was also studied in relapsing remitting MS in the FENhance 1 and 2 studies against oral teriflunomide or Aubagio. And that did show that it reduced the annualized relapse rate, or ARR, by 51% and 59% compared to teriflunomide. So that's, a good sign in the sense that, we want to make sure that this drug does work in different forms of MS. And in fact, we had some questions about this class of medications, the BTK inhibitors, in relapsing remitting MS, as the earlier studies involving other agents were really not all that impressive. So that's at least good that with fenebrutinib, that did manage to go over this bar as well. Okay, but in these combined studies, we also learned of 8 fatal events in the fenebrutinib arm, which again did not seem to be drug related, but I think we're waiting to hear more about those specific events. So more to come in terms of the safety, especially with this class of medications. Let's change gears a little bit, and we're going to talk about menopause in MS. So this is a question, again, that I get very frequently about menopause and perimenopausal symptoms. And I think, it's been this thing in MS that we've long kind of wondered about the relationship between MS and hormones, especially estrogens. But we know that, for instance, just statistically, MS is much more common in women, 3 to 1, which interestingly, actually, when it does happen, when in pediatric MS, that ratio doesn't exist. It's supposed to be more like 1 to 1, and it's not until, and you can correct me if I'm wrong, Dr. Schreiner, but it's not until girls get to puberty that you start to see that difference, that ratio of higher in females than in males. And then we also, of course, know about changing patterns as women get pregnant. And so that, hormone levels during pregnancy tend to go very high. And that's also a time when MS tends to be very inactive, versus then in the postpartum period, we tend to see a drop in those hormone levels. At the same time, there's an elevated risk of disease activity. And so there's a lot of kind of circumstantial evidence that would suggest some relationship here. And so, of course, after a certain point in a woman's life, they start to go into menopause. So this is typically thought of this transition from perimenopause to menopause, lasting about 4 to 6 years, where you can see significant fluctuations in different hormones, including estrogens, progesterone, androgens. And this is important because The symptoms of menopause include those that I've shown here: brain fog, fatigue, hot flashes, anxiety, depression, insomnia, urinary symptoms. So, and including these that I've highlighted here, you can tell that there is a kind of significant overlap between what we often associate with MS, right? And so you can see why there would be, a lot of thoughts that menopause might be related to MS or MS worsening. And so there have been some studies on menopause and MS earlier, but they kind of have led to like some different conclusions, and that can potentially be because there's different methodological issues, and I think it's just really in general hard to disentangle menopause from aging, which is something that we know is associated with MS progression. And so in that kind of environment comes this recent study published in JAMA Neurology, where they basically looked at, in this cohort, they tried to identify women who were premenopausal versus women who were in menopause, and tried to see, was there an impact of menopause on the risk to confirmed disability progression. And so that's what we see in the upper part of this. Does this have a pointer? Is there a pointer on this? No? Okay, well, the upper part of the table here refers to time to confirmed disability progression. And what you see is in the univariate analysis, meaning just looking at menopause versus no menopause, there does seem to be a statistically significant relationship with time to confirmed disability progression. However, if you go to the right side, and they did a multivariable analysis factoring in all of these other variables, including age at MS onset, baseline disease duration, baseline relapse, baseline EDSS, and exposure to high efficacy DMT, then that effect goes away, and you don't see a statistically significant pattern or a relationship to confirmed disability progression. And the same thing on the lower part of the table with time to conversion to secondary progressive MS. Initially, it seems like, yes, there is a relationship there, but then when you do the multivariate analysis and you factor in these things, especially age, then you see that, in fact, there is no relationship. And so, I wasn't sure whether to put a check mark here or a red X, but essentially it doesn't seem like it's the menopause itself that is associated with MS progression, at least. It's that, aging, or perhaps some of these other things that, of course, men, we also see men who age. And so we know that age is a risk factor for MS disease progression. Speaking of, this article was also published recently in Brain in 2026, earlier this year, about aging and remyelination failure in people with MS. And it was a systematic review looking at clinical studies, radiographic, meaning MRI studies, and pathological studies of folks with MS to try to see what kind of patterns emerge. And what they basically found was that the ability to remyelinate or myelinate, but here remyelinate, does decline with age. That remyelination is not only influenced by age, but also a number of genetic, epigenetic, and environmental factors. It's unclear what's the best imaging modality for looking at myelin or myelination. And they talked about a few different ones in this paper, ones that we kind of advanced imaging modalities like myelin water fraction, or MWF, magnetization transfer ratio, or MTR, and DTI, which I don't really remember what that stands for, but that's looking at something called fractional anisotropy. So a lot of these kind of advanced MRI measures, which are available in kind of standard clinical use, but generally speaking, have a larger role in research studies at this point. And so, like, if I looked at an MRI, or a radiologist looked at an MRI for just kind of a routine follow-up on an MS case, they're not going to be telling me about the myelin content or the amount of myelination or remyelination, and I won't be able to really determine that by looking at it. But also interestingly, in this paper, there was considerable variability in the different parts of the brain that are in their capacity to remyelinate. And in fact, cortical or gray matter areas seem to have better remyelinating ability than other areas, which was something that was curious, and I don't know why that would be. But also between individuals, some individuals seem to myelinate better than other individuals. And then there was no clear age cutoff for when remyelination was no longer possible. Remyelination capacity does decline with age, but it's not clear that there was a specific cutoff there. Okay. As promised, I'm going to talk a little bit about this lipoic acid study in progressive MS that we were involved in here. This was an attempt to find a compound that could be neuroprotective. So this was a randomized controlled trial of lipoic acid versus placebo, and the primary outcome measure was to see whether it could affect person's walking ability, so slowing progression in the walking speed primarily, and then a number of other clinical and MRI measures were secondary. So we were able to recruit 115 folks with MS, and this was primary or secondary progressive MS. Average age was 59, so a bit older than some of the other studies that we saw. And then the average EDSS was 6.0, meaning walking with a cane. About half or a little over half were already on a disease modifying. So you could still be on your disease modifying therapy because this could be an add-on or a standalone treatment. But unfortunately, in the end, it did not meet any of its clinical endpoints. It didn't seem to make any difference in terms of physical or cognitive function or anything like that. But interestingly, it did seem to slow the rate of atrophy. So you can see that in the picture here, with the red line being the lipoic acid, and then the blue lines being the people who, excuse me, the red line being the placebo and the blue line being the no, got it right the first time. Red line being lipoic acid, blue line being the placebo. And so yeah, there was a statistically significant difference here in the rate of atrophy at 24 months. So it was about minus 0.58 cubic centimeters in the lipoic acid versus minus 7.18 cubic centimeters in the placebo cohort. And that does kind of track with what we saw in an earlier study, but again, no actual physical tangible effect on this thing. And we did unfortunately uncover that a few people had a significant kidney injury who are on this drug. So it's not something that I am going to routinely recommend to folks on the basis of this study. And again, well, maybe not again, but like this idea that brain atrophy, we've talked about it quite a lot, and we've said that it is important. But here in this study, even though there was seemingly an impact on the progression of brain atrophy, there was not in the kind of clinical picture. And so that calls into question really whether that is the appropriate measurement that we should be looking at in these progressive trials. And that was also that disassociation was also something that we saw in the earlier Hercules study with tolebrutinib in non-relapsing MS. Yes, I have to get through these last few ones. Okay, so Pipe 307, this was one that some of you had asked me about a while back, and I hadn't heard of, but it was based on this kind of earlier preclinical work that seemed to suggest a lot of potential benefit in remyelination. It works on this M1 muscarinic receptor, and so they did this smaller phase 2 study in relapsing remitting MS where people received one of 2 doses of this Pipe 307 versus placebo, and they tested whether it would improve vision, and then secondarily some of these other functions, walking, hand function, cognition. But unfortunately, it gets an X because it did not show any of those benefits that were hoped for. Then moving on to this RERAP study, bezadoxifene, which was another smaller study looking at this compound that affects estrogen, and again with estrogen, and hoping to show that it can produce remyelination. So they enrolled 66 women with relapsing remitting MS, aged 45 to 60. And they used one of those advanced MRI metrics that I mentioned, myelin water fraction, to try to see whether it could repair the myelin. So in the end, it was well tolerated. There were no significant severe adverse events, but it did not, in fact, unfortunately, have any difference in that myelin water fraction in this band of white matter, the corpus callosum, at either 3 or 6 months. So that kind of raises the questions, and it's not just for this study, but for really all of these potential remyelinating or repair studies, is how do we design these trials? Like, who should we be recruiting? Should we be giving the medicine earlier on, later on? We know that earlier on it may have a more of an impact based on that review study of remyelination that I mentioned, but later on is where a lot of the need tends to be, right? And then, what's the optimal length of time that a person should be taking it? What is the optimal endpoint, MRI metric, blood, CSF? Like, what's the optimal kind of thing that we should be looking at? And kind of how do we make this pipeline more efficient? So it's not just like one kind of interesting drug that pops up and then we test it and it takes a few years and then we get some results and it's like, and then we do it again and then a couple of years later and it's like, So like, how do we make that pipeline more efficient? I think is a really good question. And then finally, I have this, or maybe a couple more slides, about this K102 compound, which is kind of an interesting story. This is chloroindazole-based estrogen receptor beta ligand, meaning it acts on this estrogen beta receptor. This was a compound that was developed or found by screening 60 plus indazole chloride compounds identified by researchers at the University of Illinois. It acts on this estrogen receptor beta pathway. And then again, in the test tube, seems to promote myelination by these cells, the oligodendrocytes that produce the myelin. And in mice models, at least, of MS, was able to show improved function and also reduced inflammation in the optic nerve. And so it gets a purple question mark because we don't yet have clinical trials that show benefit. So this is another one that's like, oh, very interesting. Like, it has a nice mechanism of action. We think, this might be a relevant pathway, and it seems, at least in mice, to produce benefit. So let's see what the clinical trials show in humans. And so that's what I'm looking forward to. And then I promised the slide on CAR T therapies. I know there's been a lot of interest in these recently. CAR T, that stands for chimeric antigen receptor engineered T cells. So these were an intervention that was originally developed for cancer and then now being explored in MS and other autoimmune diseases. The idea is you're taking a person's own cells, particularly their T cells or T lymphocytes, and you're engineering them to target other cells. And so in the case of MS, that's mostly targeting B cells, because we know B cells have an important role in MS. And so there's potential benefits here. The idea that you could get this intervention and then you wouldn't necessarily have to keep re-administering medicine like an anti-B cell therapy every 6 months or whatever, because you still have these cells circulating in your body. So it's kind of a longer lasting effect potentially. Maybe it's able to get into these areas, these entrenched reservoirs of B cells, like in the meningeal follicles that we talk about as potentially being related to progressive MS. So maybe these cells could go where other treatments couldn't and go after those cells, which might have a relevance for progressive MS. So it gets a purple question mark because we don't really have a lot of data yet from humans, from MS clinical trials, specifically mostly just from mice. And then there's been a few case series of this. And so my conclusions, we've got some mixed reviews, I would say, from the BTKs. Initially there was a lot of kind of hype about these, and I think that enthusiasm has kind of come down a little bit, but I think there's still potentially some promise, especially in progressive MS. And I do believe we have a study for one of these drugs, remibrutinib, that is currently in startup, but will hopefully be coming out soon for enrollment. This would be in secondary progressive MS, including people up to age 65, including people up to EDSS of 6.5, meaning walking with a walker. So if you are interested, please see our research associates in the back. Menopause, we talked about as being potentially, associated with neurological symptoms, but not necessarily MS progression. We know that aging is associated with decreased ability to remyelinate. Several of these kind of maybe hyped I'm using too strongly, but like several of these promising compounds, lipoic acid, PIPE 307, and beta-doxyphene, did not appear to show any benefit in remyelination or neuroprotection. Jury is still out on CAR Ts for MS, and I didn't even get a chance to talk about hematopoietic stem cell transplantation, which I know you guys often have questions about, and I would say jury is still out on that. But we do also have a trial that is enrolling for that, the BEAT MS study, for folks who have a really active form of relapsing remitting MS that is not responsive to current immunotherapy. So with that, I thank you for your attention, and I look forward to the question and answer session.